Okay, everybody. We're in the final session of the conference, and it always amazes me how the time passes in these conferences, especially when you're organizing them. They seem to go very, very quickly. So we're in our final panel session, which is about preparing aging populations for climate change in British Columbia. Our first speaker today is Larry Frank. Larry is the Bombardier Chairholder in Sustainable Transportation at the University of British Columbia and is Senior Non-Resident Fellow of the Brookings Institution. Larry specializes in the interaction between land use, travel behavior, air quality, and health. So, Larry.
Good afternoon. I'm gonna jump through some stuff that I covered. Some people were here the other day, and I gave part of this, but I've changed. So it's the same initial slide, but I added in more on the climate change side to talk about that a bit more today. Just in review for those of you who did see and then knew, how many were not here? Not at the event on Tuesday. Okay. There's some relief to that. Although Mike's, I feel bad presenting in front of Mike. He's seen my work too much. So anyways, I'm just going to go back over this, but a lot of the research that colleagues and myself work on is to try to understand the relationship between the design of the environments where we live and how that affects our behavior and how we travel and how that might translate not only into travel patterns but into health impacts. And you'll hear from, is Mike speaking next?
Yes, Mike Brower is next. Yes.
Good. Okay. Well, I'm trying to know. Okay. So I just know the order, so that helps me in context. Some of our are in the School of Population and Public Health and Environmental Health at UBC. Look at air pollution exposure issues. Mike does a lot of that, and other types of research as well, looking at different types of exposure. I look more at where people go and how they get there and how active they are, a little bit more focused on physical activity related to travel. Real quickly, a household in the upper left is in a neighborhood that's fairly single use. It's automobile dependent by many different dimensions. It's in an environment that precludes the ability to walk to any other use that might be complementary to residential. So you think of residential and retail, shopping, employment, these are complementary functions, and when they're not co-located in space, then we have to travel further. It's a very simple concept. It's how we've built our communities, mostly for the last half century, although there are many exceptions. On the right is a neighborhood that's more heterogeneous in use. It's more mixed. It's more dense. It has a lot more of the types of things that we would think of live, work, play. Another way to think about it is the lower diagram. A to B is 2 kilometers, which is a little further than most people are willing to walk, whereas on the lower right, this one here, backspace, is same distance, airline distance, but in a grid. The connectivity is greater, so proximity, connectivity, walkability. We talk about walkability a lot. Haven't really had a lot of data on sidewalks to date. We're just now importing sidewalk data into walkability. So all the research that you've heard on walkability, if you've heard of any of it before, there's a lot of really good researchers working on this topic. There's a lot of work that's been done. It's been done without sidewalks for the most part. So we're now getting sidewalk data into the GIS measure of place to understand how people get around. For aging population, sidewalks are pretty important. But not just having sidewalks, it could even be cross slope or slope going up and down, too steep in one spot, not walkable. Hit an intersection and the grocery store's on the other side. Takes too long to get across the street. Not going to work for an elderly person. So very quickly, walkability has a whole new dimension. On the climate change side, there are 3 ways to reduce CO2 emissions through travel. This is not talking about energy use of place, just the travel side. Fuels and vehicle efficiency reduce CO2 emissions per unit of distance traveled. Demand is the other part of this. So making places so that we don't have to travel by car and it's easier is really critical. One of the ways to think about this, and we just finished a paper about a year ago in Preventive Medicine, it was released, called Carbonless Footprints. And the idea was we just took all the trips we all make and we converted them to joules, to energy units, and divided active transportation in a numerator by sedentary travel in a denominator, and came up with an index so that we could start to get decision makers to think about a transportation energy index, because of course that's sort of a fulcrum. And just a little anecdote on a slice of pizza, or 350 calories an apple tart, or a special slice of raised pizza, a cyclist can travel 10 miles, a pedestrian 3.5, and an automobile about 100 feet. Whether or not that's exactly right, depending on the car, the type of bike, and the person, is a little bit variable. But the general concept is that, the most fuel efficient, energy efficient mode of travel is probably a bike. And then we walk, and then we have the car, which is not so efficient. And that's how we're getting around. So just a way to think about it. Mapping this is not that hard once you measure things. Just an example of Vancouver. Green is walkable, red is not. There's not too many questions about that, I bet. And then the measures, you can start to sort of illuminate them. I went through this the other day, but many of you weren't there. So density, mixed use, intersection, or connectivity. Just showing people, comparing communities. We get into a lot of political debates over what is good, what is walkable. Everybody thinks their neighborhood is walkable. If you talk to people in Queensboro, they'll say, we're walkable. We walk for recreation and in the evening, perhaps. There's a lot of walking for recreation or leisure, but not for utilitarian purposes. And for elderly, that may be okay, but it's not going to solve the climate change problem. And then you have the question about exposure and the aggregate effects of heat and other things that come from exposure, adverse impacts. So walkability in elderly is something that we looked at. I showed this the other day, but one of the things that you can do is start to determine where you might have problems by crossing walkability, or lack of access to transit, lack of access to shops, services. That's what this is showing, and where people are older. So you cross-reference demography with urban form, and you get some answers about where problem areas may be, and that could help with programmatic decision making. Just a concept or an idea just to show the notion. And with the census data cross-reference with this, and anybody can do this in other regions, you end up with, you could just take walk score, which is everywhere, and do that. We're talking with them about that as well. So you basically convert and say, well, query the data and want to know about lower income, elderly, of across gender, and so forth. So it gives you spatial information. Aging populations are wanting to move, or moving now, to urban areas, which is driving up the price of urban settings. So we have a housing affordability problem. Seattle is seeing this. Just show an example. So in 2011, you can see the concentrations of elderly growing very quickly. This is a projection. Now it's the year 2011. This has already been exceeded. We're looking at census tracts, and the percentage that have over 25% that are 60 and older is really quickly filling up. And with aging baby boomers now 65, the pressure's on. And how are we going to deal with it? One of the things I'm really interested in, and hope that you cover, I don't know if you were able to discuss this, but aging in place, and the whole issue around the ethics behind that as the thing to promote, because there's a lot of places that healthy aging is hindered by. What an elderly person might want from a health aging perspective is opportunities for, research shows, social interaction, maintaining independence. You all know this. You probably know this better than I do. Distances are short to destinations, and there's a variety of housing choices. Streets are interconnected, sidewalks are even, and so forth, with parks and open spaces and not too much slope. Done a lot of work in Atlanta. Just shows the walkable areas in the dark and the core. I'll just mention this, that of the 11,000 square kilometers that Atlanta covers, only 47 square kilometers registered as having even a moderate level of walkability. So, and I always, you're a new group to me, but the Ted Turner joke that Ted Turner said, thank God for the Pacific Ocean, because at least there's something to stop Atlanta's sprawl. So, you all look like you needed a job. So one of the things we've started to do, and this is I try to do the work on this with my students, is to say that some of the most powerful information is the simplest information, is just descriptive. So we start looking at elderly, compared to general population, 65 to 74, 75 to 84, and 85 and older, and look at percent with no driver's license, as you'd expect, increases, percent with a medical condition, impacting travel, increasing, just starting to understand across the different age ranges of aging, just to get a sense of what the issues are. And you can look at the travel patterns, and it may be that there's a lot less travel occurring, but it may be that there's actually the latent demand for travel, and it's not revealed or manifest because the opportunities aren't there and the services aren't provided in a way that's convenient. So I think it's just a way to think about information. And another one is, this is from the models we recently ran on a data set we had in Atlanta, which is why I'm mentioning Atlanta, where we looked at the top row, 65 to 74 versus 75 and older, the three age groups I just mentioned. And you can just look at the sample size, where you see the numbers, and we have 85 and older, there's fewer. And then we just looked at percent that walked at least once over 2 days, steadily declining, percent travel in car over an hour, which is a predictor of obesity and other problems, declining. And then percent that meet the MVPA, moderate and vigorous physical activity guidelines, of 150 minutes per week. And you see the decline in that, but probably understood and anticipated. But it's nice to get a sense of what those numbers are. So we took 1,970 elderly, 65 and older, and did a study. We're doing a few more now, and looked at over a 2-day period of travel. And that we had their demographic information, height and weight, and then we looked at the relationships between the design of the neighborhoods where they live and and basically what this says is the methods is the urban form spatial match of these folks and their health characteristics. What we found was increase in walkability, meaning the composite measure of mixed density connected street network and having shops and services set up to the street, not behind surface parking, was associated with a twofold increase. A 2.02 odds ratio. Increased walkability is related with more walking, less time spent traveling in a car, and lower odds of being overweight. Those with one or no cars were more likely to walk, significantly more likely to walk, as you'd expect. Vehicle ownership at the bookends of the age spectrum we see for youth and elderly. Vehicle ownership is a critical issue, and incentives to have lower levels of vehicle ownership will solve a lot of our physical activity objectives, but we have to have an urban form, a physical environment where that's even reasonable to even propose. Otherwise, it won't work at all. But also, those that without a car are less likely to get recommended levels of physical activity. So some sensitivity to the kind of environment people live in, because if elderly, like in Atlanta, are living in a place where there's no recreation nearby, no physical activity, no opportunities, no amenities, then they're going to have to have a car to get there. And this just reveals what we thought. So, and then we also saw, fast food outlet visitation was associated with increased odds of obesity, but that's really limited. That assumption about food outlet type, good, bad, fast food versus sit-down restaurant, is ridiculous. The evidence is now starting to show that you just have a wider range of food choices in restaurants. You can eat worse in a restaurant, sit-down restaurant, than you can in a fast food outlet. And in fact, many fast food outlets now have healthy food choices. I'm not funded and supported by fast food industry, but I think that there's something that's sort of oversimplified. So we have to look at this. It's really how often people eat at home and prepare fresh food and get fresh fruit and produce. That's a good indicator of their health and their body weight. Seems to be what's coming out of literature. So very few people, I'm just going to jump ahead, healthy aging and time spent in cars. We care about this. More time in cars, more sedentary behavior, more obesity, more greenhouse gas emissions, more air pollution, and so forth. Also safety issues for elderly. All that comes together. The youngest group and those with a higher household income and a degree were more likely to travel more in a car. I just wanted to mention this indicator. I'm just going to jump ahead and talk about body weight. Those who walk were significantly less likely to be overweight, as you'd expect. Women and those with a degree were less likely to be overweight. Younger participants were more likely to be categorized as obese. One of the complexities of studying body weight and built environment relationships in elderly is the nonlinear relationship between body weight and aging. In fact, so over a certain age, it goes down. So this is a critical issue and helps to understand that and understand the results that you get. I went through a big experience on that whole conundrum, the whole issue on a little contesting of our research. I'm going to jump ahead. Mike, you might want to do that. Basically, what about where older Americans go for food? We're starting, and this clearly must be a core thing you've been talking about over the last day or so, I would imagine, is food access, certainly from a CO2 perspective. And we've been talking about an intervention. I've been the last day or so writing. We have a proposal due in the downtown core here to look at how we might retrofit a corridor in the downtown Vancouver area to support a variety of things, including healthy aging. And one of the key things is thinking about where elderly, is integrating food growing opportunities into urban settings. Difficult in a high land value context like this, but essential. So there's trade-offs we have to understand for fresh food. One thing I'll mention is this is high walkability, high income, high walk, high income, low walk, low income, and the other two combinations. And what you see is a pattern typically emerging that we have seen in other studies is that on the lower income side, there is more fast food. And on the higher income side, there are more grocery stores. And so the food desert issue is critical for elderly. I hope this came up at one point, is if the only food outlet nearby and your mobility compromised is something that doesn't offer you healthy food choices, you're exponentially exposed to and dependent upon something that's bad for you. And conversely, if it's healthy, you'd actually have the opposite effect. So it actually could be a good thing. So if people can't get to anything other than something good for them, then maybe you have a health opportunity. I never thought about it that way. But anyways, policy implications is needed to bring older Americans and Canadians closer to shops and services, North Americans, and healthy food outlets as a means of encouraging regular walking and healthy body weight, and incentives to encourage neighborhood grocery stores and affordable housing in central areas with regulatory reform through zoning can encourage physical activity and healthy body weight in the elderly. Regulatory reform, one of the key things about zoning is we know zoning is a tool that is underpinned by health, safety, and welfare. That's how come we have zoning. But we actually zone out a lot of healthy things, and we zone neighborhoods and places to be single use and require people to travel by car through zoning. So the health-based mandate of zoning is very questionable from a legal perspective. There's now evidence to challenge it. Probably only a matter of time before that happens. May happen in the next 5 to 10 years. My last point is on residential preferences, where we choose to live. Our preferences, and I heard when I came in a discussion about preferences and attitudes and values shaping behavior. I think maybe it was during your talk. We make trade-offs, forced trade-offs in a sense, because we have to sometimes can't have everything. We can't have a mansion next to the walkable strip. Not everybody can live in what we Shaughnessy here, where you can walk down to Meinhardt's and get a wonderful, in a walkable distance. Those houses are about $5 to $10 million now, and there's not that many of them, even if you had the money. So anyways, just one of the things to think about is, as we think and move forward with policy considerations, all the discussion I just said was on the horizontal axes about where people live. Low versus high walkability, but operating at the same time, and perhaps as powerful, if not more, is our preferences that are shaping our behavior as well. So if you want to be but aren't in a walkable neighborhood, or you want to be in R, or you're not in a walkable neighborhood and you aren't, these two combinations, people are matched, they're happy, they got what they want. And over here, you're in a walkable neighborhood and you want to get out, perhaps because of air pollution problems or other things, historically. Those are important to know, because those two things together form and affect our behavior. One of the things that researchers can do to understand this is to cross-reference preference or choices people make with their preferences and scatter their data to understand how people behave under these different conditions. We did that. Here's a result of a paper called Stepping Towards Causation, where we saw the upper two quadrants, as I just showed you in the scatter plot, are left quadrant 1 and quadrant 2. And what we see is for these people want to be and are not in a walkable neighborhood, the percentage that walk was 16% versus 33%, or more than twice as many. Similar preferences, we had 7 forced trade-offs using a principal component factor score. We have a pretty good sense of their preferences. And what we see is people, no matter even if you want to be but aren't in a walkable neighborhood, you're not enabled. So it raises the question, is that, and we saw in the models that followed the regressions and the logistical regressions that we did, that actually this is the quadrant we should possibly be looking at, because a lot of people have traded off walkability for other things, for other reasons, because it has, perhaps it's priced out of the market for them now. In elderly, this is happening. So I hope this issue comes forward. And we also see vehicle miles traveled, a good predictor of CO2 emissions related. And on the CO2 wrap-up, one of the things that can help is to start to map convergences between exposures that are adverse and opportunities that are health promoting spatially to identify places where it's healthy to age. And that could be done through an indexed approach. And I was just talking with the Area Agency on Aging in Seattle about the transformation grant opportunity in the U.S., where there's several $100 million being allocated to try to do some things and then evaluate them. And one idea could be to actually take an approach to stimulate elderly to have a pot of money that gives an incentive for elderly to move while they easily can to a neighborhood that has all these health benefits without as many of the disbenefits. Thank you.
Thanks, Larry. We'll move on to our next panel speaker. If we've got time at the end of the session, we will take some questions and answers. The next speaker is Michael Brower, who is professor in the School of Population and Public Health at the University of British Columbia. Michael also directs the BRIDGE program, a strategic training program linking public health, engineering and policy. He's recognized internationally for his research on air pollution exposure and health impacts. Michael has participated in studies throughout the world and served on advisory committees to the World Health Organization, the US Academy of Sciences, the Royal Society of Canada, the International Joint Commission of Governments in North America and Asia.
All right, thanks very much, and thanks everybody for staying to the bitter end here, almost the bitter end. So what I'm going to talk about is some linkages between climate change, air quality, and chronic disease, and try and put all of this with a positive spin, because I really think there are some really good opportunities, actually. So key themes that I want to cover is when we actually talk about mitigation, ensuring that those mitigation strategies actually don't worsen health, don't worsen actually health problems that we currently face. Think about climate mitigation actually as an opportunity, and following that, designing healthy cities, both for climate resiliency but also for health in its broader sense. So Heather actually asked me to give this a bit of a local, a BC flavor, so I'm going to do that, but I actually can't fully do that, so I am going to talk about things a little bit more globally. Just a little bit of background on air pollution and health that I think is important so you understand sort of where I'm coming from. Air pollution, the risk, and I think this actually goes for sort of many climate stressors, the risk to an individual actually is rather small. But we have a large exposed population, and therefore on an aggregate the population risk is large. And you can contrast that with something like smoking, where if I smoke a cigarette, the risk to myself is quite high, but on a population basis, fortunately not that many people smoke. So it's actually decreasing in terms of its public health emphasis in many countries. What makes this important, though, is that air pollution management is very cost effective. So actually, if you improve the air quality, you get big benefits because everybody benefits, as opposed to one person. So it's a very classic sort of public health problem, but we actually see this in our economic evaluations. What do we know about air quality and health? Well, we know on days with worse air quality, more people die. Most of these deaths occur out of hospital, so these are not immobilized, extremely sick people. But they are people that generally tend to be over 65. So it is an impact that affects the older segments of the population, but probably not the most frail segment of that subset. We also know that in more polluted cities, people die earlier than less polluted cities, so it really has a measurable impact on life expectancy. And more importantly, I think for the kinds of things that I'm going to focus on, in the most polluted areas of cities, there's an increased risk of dying. So it really matters where you live in the world, but also actually where you live in a particular urban area, for example. In Canada, so here's the local flavor, arguably some of the cleanest air quality in the world. And in fact, this city, for a city of its size, is probably one of the cleanest in the world. But we can still measure the impacts of air quality, and they're not tiny. So around 700 deaths per year attributable to air pollution. That's about 5% of the total. So it's not trivial. About 65% of those actually have to do with chronic or long-term exposure. So air pollution both sort of kills in terms of acute events, but also I would say more importantly, its influence on progression of chronic disease. So in a sense, it makes you age. If you think about biological aging, it makes you age more quickly. This is just the global pictures. You can see this figure here, which is based on some satellite-derived estimates. Again, Canada, very clean. Where's the worst air quality in the world? Well, primarily it's in Asia. And actually what you see in Africa is primarily wind-blown dust, which is not benign, but doesn't have the same level of toxicity as sort of anthropogenic air pollution. When we sort of put this together with population, and so this is part of the Global Burden of Disease project, we estimate that there's about 800,000 deaths per year attributable to air pollution in cities, but 2/3 of that is actually occurring in rapidly urbanizing Asia. When we actually think about all the transitions that are underway in Asia today, including the demographic transition, so the aging populations, even if air quality stayed exactly the same, more people will be affected because of demographic transitions, because of urbanization, and in fact because of the epidemiologic transition that we're seeing as a shift towards more chronic disease. So, and again, these tabulations, these 800,000 deaths per year, are adult chronic diseases primarily and affecting the elderly. So this is actually just looking at cardiac and pulmonary mortality and lung cancer. Another air quality issue that's actually by far more important and has far more greater linkages to climate change I'm not going to talk about today. It's a whole other issue, which is indoor air pollution from household cooking. And actually there's amazing opportunities for co-benefits looking at that health problem and its contribution to climate. So locally, what are the impacts? We have summer smog. I think probably everybody's experienced this at one time or the other. In terms of a climate change, we know that we're going to experience both an increase in episode frequency and magnitude. Interestingly, these tend to coincide with extreme heat events. So it's multiple risk factors. In terms of the public health, opportunities in terms of co-benefits, but there's also some things we need to be aware of that may have disbenefits in terms of how do we deal with these issues. So we know actually that climate change and air pollution that affects us, let's say via smog, have common sources. So if we reduce those sources in total, we get multiple benefits. But it actually depends on how we reduce things. So for example, diesel vehicles are actually good for climate. If you shift from gasoline to diesel, that's actually good for climate. It's bad for air quality, bad for the health impacts of air quality. And there's been an example actually of a climate policy in the UK that led to a shift in diesel vehicles, and the estimates are that actually increased health impacts due to the air quality, as well as actually traffic accidents because people shifted to smaller cars. But not everybody shifted to smaller cars. So you had big cars, small cars. Traffic accidents are actually more fatal in that situation. Locally, we have another sort of scenario, which is biomass. So if we think about using biomass fuel, that can be argued as a climate neutral fuel, but it could be worse for air quality. So we actually have to be aware of these possible disbenefits. Locally in British Columbia, I would say actually the greatest air quality impact that's going to be mediated through climate change are wildfires. We know very clearly that with the changing climate, we can already measure this, that we see more fires. These fires are larger, and the fire season is longer. So those of you who live in this area, this is a picture of Kelowna. Here's a fire, and you can see the smoke impacting these communities. And when I first started, and I've actually been researching this issue for too long, actually, I won't say how long. This is, I would say, a relatively rare event. I actually got started in this with a big episode that occurred in Southeast Asia, Malaysia, Singapore, due to fires in Indonesia. Now this is actually a regular event, not just here, but in Europe, as well as Southeast Asia, where it still continues. So this is a figure that Sarah Henderson put together, showing just last summer. And what you can see, all the colored dots are fire intensity. This is actually, again, from satellite imagery. And the black dots are communities. And so there's thousands of fires. And what's happening, though, is actually they are intersecting more frequently with populated areas. So we have more fires, because these fires are larger, they're more likely to actually to affect populated areas. So again, this used to be a rare event, but here's a major city. Here's Edmonton last summer, and you can see the smoke from the fires. So these people are doing the right thing. They're getting all their physical activity, but yes, they're breathing fire smoke. And again, this is in the summertime seems to be regular. We see the impacts on health. This is some work that we did several years ago with a severe fire season in 2003, and we saw a 50 to 75% increase in physician visits for respiratory disease associated with the smoke from these fires. We do have health protection measures, so there are things that we can do on an individual level, similar to sort of what we do with heat. We can think about clean air shelters, just like we have cool air shelters. Instead of air conditioning, we can think of air cleaners. But there's also things that actually have climate linkages, thinking about actually how we manage the land, how we manage resources. What are we actually doing with this biomass? Can we actually think about burning it, composting it, doing something with it where we can actually get energy instead of letting it burn in an uncontrolled fashion? But again, we need to be careful about that. And then we also have forecasting and sort of surveillance approaches as well. Another thing I'm not going to spend any time on, but it is an important climate impact on air quality is pollen. Again, we're already measuring this. So we have an increased ragweed season, and too bad for us, but actually it affects the high latitudes more so than lower latitudes. So in Canada already, we're seeing a 1 month longer season of ragweed than we had. This is from 1995 to 2009, already 1 month. And again, if things warm up, this is going to continue. So now, just to focus on urban air pollution has multiple scales. I'm going to talk really about the local scale, but of course there's regional and sort of urban. The local scale, one of the things we're really concerned with is sort of the impact of traffic, and this is both an impact of the level of pollution that's coming out of an individual vehicle and the number of vehicles, but also how close that traffic is to populated areas. And when we sort of put this information together, we can actually develop these sort of high-resolution maps where we can actually see on a 10 to 30 meter basis levels of pollution changing, primarily as a function of proximity from roadways. So this is good, it's interesting, it's useful. I also think it's an opportunity, and let me give you one example. So this is sort of a natural experiment that we did in one of our studies where we looked at people, these are actually adults over 45, and we followed them and looked at who died from cardiovascular disease and tracked their residences. So people, and just focus on the part with the circle, these are comparing people who lived within 50 meters of a highway to people that live more than 50 meters of a highway. What you're seeing on the top figure there are people that throughout the whole period, the 9-year period that we followed them, they always live close to the highway. they had about more than a 50% increased risk of dying from cardiovascular disease compared to people living more than 50 meters away. So we knew that already. It's bad to live close to a highway. What's more interesting, though, is we have these two other groups, and I'll focus on the circle there. Those are people who move closer to traffic during this period. So even though prior to that they lived away from traffic, when they moved closer, their risk was almost as bad as people who were already living there. Again, bad news. But the line there with the diamond are people that moved away. And their risk dropped almost down to people who had never lived close to a major road. So this is just like smoking cessation. It's traffic cessation. Now, this is talking about people moving. And of course, not everybody can move away from a major road. Not everybody wants to move away from a major road. What if you move the road away from the people, though? And so that's really where the focus needs to be. So we started thinking about this sort of as a way forward, and actually got together with Larry. And now we first talked about, let's think about walkable areas and think about pollution areas. And so Larry already told you about the relationship between urban form and physical activity. When we put these sort of two pictures together, green is good, red is bad. Unfortunately, this is Vancouver, things don't look so good. So the green areas are places that are walkable, but also have low air pollution. The red areas are places that they're bad for everything. They have high air pollution, and there's unfortunately many more of those. So the challenge right now is to really understand those green areas and figure out what it is about them that allows them to exist. And they do exist. We're also sort of looking at tools to merge various sources of information. So I do a lot of research on cycling. One of the things we've done is actually developed a route planner that will route you from A to B, but you can do it in a way that avoids hills, you can do it in a way that avoids air pollution, and you can do it in a way that sort of optimizes all of these things. And now that might not be relevant to everybody, but when I've actually presented this to community groups, people will say, you know, I actually use this for walking now. I want to know, like, I don't want to go up a hill when I walk. I can use this, or I don't want to go through a highly polluted area. So I think we can also provide these kinds of tools to people. So just to close, what we need are strategies to separate roadways from people. I'm not going to go through the list of these, but suffice it to say from the pictures, so I think you can recognize that's Times Square on the top. This is in Seoul, Korea, where they've actually taken out a freeway and made sort of an urban park. They've uncovered a stream that had been buried under the freeway. This is possible. If you can do it in Times Square, you can do it anywhere. And interestingly, in both of these scenarios, there's been no impact on traffic congestion. So that line that, you know, if you take out the road, well, you know, we're not going to be able to get around, you know, we know that's not true. People actually want these areas for all the kinds of reasons that you've been talking about the last few days. More importantly, I think in the initial stages, we actually need to focus on what we would call sensitive land uses. Where are our long-term care facilities? There where the land is cheap, that's alongside a busy road. And we see that time and time again. That's where they're being built. Same thing with schools. So it actually works at both segments of the age spectrum. We need to be thinking about reducing barriers to active transportation, understanding what are the negative determinants. And again, we're doing a lot of that in our cycling research. I lived for a year in the Netherlands, and one of the most striking things about the experience there, of course, everybody cycles, but what's really different there is that seniors cycle. And so their mobility, their sort of social interactions are completely different than they are in countries where you don't have that ability. Now, of course, you know, the Netherlands is flat, but you know, again, look at the scale of that street in terms of safety. There's, you know, no cars. There's, you know, people walking, people cycling. It's feasible. It's possible. So we need that infrastructure to promote active transport, mixed modes, you know, sidewalks. You've talked about bicycles, et cetera. Again, just in case somebody tells you, you know, this is too expensive, we can't afford this, think about the future. Oil prices are not going down. They're going to go up. So this actually becomes more affordable over time. So again, I think there's real opportunities here. So I will close there. Thank you.
Okay, we'll still save questions to the end. Thank you. Our next speaker, we're just determining that.
Yeah, no, it's not.
Sorry?
It's, I've got the files.
Okay. Yeah, there was an issue to do with the presentation, whether it was loaded or not. Okay. Our next speaker, is Alec Ostry, who is professor in the Faculty of Social Sciences at the University of Victoria. Alec? I'm here. Oh, hi, Alec. Oh, yeah. Sorry there. Alec holds a Canada Research Chair in the Social Determinants of Community Health and is a senior scholar with the Michael Smith Foundation for Health Research in British Columbia. He has a Master of Science in Health Service Planning, a Master's degree in History, specializing in the history of public health, and a PhD in epidemiology. Alec.
Good afternoon. I am the penultimate one here, I believe. So great to see you this afternoon. Thanks for the invitation. Just to let you know, this work is based on 2 documents. The Pacific Institute for Climate Change Solutions approached me about 2 years ago and said, would I write a paper looking at the potential impacts on health of climate change for British Columbians? And about 6 months ago, they approached me and said, would I look at the impact on food security for British Columbians of climate change. So this work is essentially based on those 2 documents. I'm kind of faking the seniors part of this, I'm sorry to say, because I'm not a gerontologist, but I've thought about this in relationship to vulnerable populations in general, but I'm not bringing a seniors lens to this in an expert way at all. Anyway, the purpose of my talk is to take a social determinants approach. Can you hear me if I back away a little bit like this? Take a social determinants approach to identify communities that will be highly vulnerable to the health impact of climate change. I'm interested in identifying communities and using the same framework, explore the potential impacts of major indirect pathways. I think we need to look at indirect pathways. I think these are very important, and I'm particularly looking at food insecurity. And the reason I'm looking at food insecurity is that a large proportion of seniors' budgets, people on fixed incomes, is going to food, and the impact of climate change on food and on the price of foods for people on fixed incomes is going to be a big deal, in my opinion. So, the outline of my talk, I'm going to give you a little introduction, talk a little bit about a social determinants approach to the study of climate change and health. I think we need to take a more social determinants framework to this issue. Talk a little bit about the changes, potential changes to climate in BC that will likely emerge. Talk about pathways by which the health of seniors may be affected. I want to talk particularly about the vulnerability of rural British Columbians and why. And then this food security pathway business. Much of the research on health in relation to climate change is based on the impact of major weather-driven disasters on health. Hurricane Katrina is classic. And it's interesting how you mentioned in Britain it's sort of not that relevant to you because you're worried about floods. BC is a huge place. So we're worried about floods and about drought at the same time. And it's important to understand that. Think about these exposures in relationship to these large biogeoclimatic zones we've got in BC. Research frameworks describing the linkage between climate change and the main diseases of concern for seniors, cardiovascular disease, cancer, diabetes, have not been well articulated. And that's a huge issue. Like if you look at a lot of the research, it's about malaria, it's about infectious diseases, it's about, in a secondary sense, about war, immigration, famine in third world countries. Given the complex way in which climate change will act in concert with other socio-economic and environmental factors, it's best to approach this study, I think, using a social determinants approach. Several models have been developed in order to frame research on the impact of climate change and health. McMichael in Australia has been good at this. Most of them focus on, as I said, developing nations. They tend to have large populations already suffering from ill health, few resources to adapt to the direct or severe weather events or indirect long-term issues. In most of these models, climate change is conceptualized as impacting human health directly or indirectly. Direct events, we've heard a lot about that at this conference. I won't go into that. Indirect health effects arise from the sustained impact of altered climate, which causes changes to ecosystems, and which in turn impact human health. And I think we have to begin to look at those sorts of issues. For example, rises in temperature may alter living conditions for animals and plant vectors of disease, with subsequent very difficult to predict impacts on human health. Lyme's disease in BC is a potential issue there, as is West Nile, as is C. gatti. Other models posit more complex pathways from climate and ecosystem transformation, impact of social dislocation and migration that might arise from these broad changes. Still, other models focus on secondary health effects such as malnutrition, vitamin deficiency, attendant to medium and long-term adverse changes, et cetera, et cetera. Here's the key thing, I think. The magnitude of these direct and indirect effects of climate change and health will be a function of the nature and the magnitude of climate changes and the vulnerability of affected populations. So we need to look at exposure, intensity of exposure, and we need to look at that in conjunction with vulnerability to subpopulations. So the task, a prioritizing task, is to understand the potential for exposure, and understand who in the communities being exposed, which communities are going to be vulnerable, and who within those communities are being vulnerable. And I think to take Dr. Hack's point of view is to try and raise the general resilience in these populations over the long term. What can a social determinants approach offer to identify these kinds of communities, to identify the most vulnerable groups in the communities, and also start to think through the pathways by which these vulnerable communities will likely be impacted, and then develop proactive adaptation strategies. What I'd like to do now is talk a little bit, very quickly, about likely climate changes in BC. And you know, this is pretty hocus pocus. If you talk to Andrew Weaver and other experts in this area, the evidence is really minimal. There's not a lot of direct evidence, but it looks like we're going to have wetter, warmer winters in most regions of the province in the summer, in the winter and the spring, and we're going to have reduced snowpacks as the glaciers melt, rapid melting of alpine glaciers, changed stream flow volumes and timing, especially with spring snow melt occurring earlier, increased winter runoff for most of BC, changed groundwater recharge rates, reduced summertime flows in many BC rivers, and sea level rise. What will be the impact of these sorts of changes on the health of British Columbians? The first thing, there's virtually no direct evidence. The papers on heat wave impacts in British Columbia are recent, very positive developments here. It may be possible to extrapolate from some of the evidence. It's likely that the changes will act on the health of British Columbians through physical, biological, and socio-economic pathways. As Mike mentioned, we're going to get more exposure to fire. And here's where we have to really think about rural areas, and we have to think about, it's very important. Also, the mixed, I can't seem to say the word, concomitant exposure to heat and air pollution mix is going to be a big deal. Urban heat islands, floods on the coast, plagues, beetles, frogs, you name it. Floods and groundwater contamination. This issue of flood and contamination of agricultural land is a huge issue around food security. Drought in the Okanagan is probably going to happen, and the Okanagan is mainly a central valley in British Columbia, which is mainly dependent on irrigation. Here's a big deal in this province, and why we have to be quite aware of context. Again, something you mentioned. Mountain pine beetle infestation and associated logging will exacerbate flood and fire risk, both in certain parts of BC. So these are important. Biological pathways, waterborne diseases, many respiratory pathogens such as influenza will shift their patterns as well, et cetera, et cetera. Altered living conditions for animal and plant vectors of diseases. Socioeconomic pathways will be important. From the socio-determinants models of health, we know that differences in chronic physical and mental illnesses are driven by economic and geographic factors in many ways. We also know that in BC, the main diseases of interest are hypertension, coronary heart disease, cancer, mental health. All of these illnesses are diseases whose prevalence varies in subpopulations depending on different socioeconomic contexts. It's important to look at communities most exposed to climate change and those communities with the socioeconomically most advanced, disadvantaged people. That's why we've got to look at rural populations. When you look at the numbers of in terms of the health status of rural British Columbians, are quite astounding, particularly health status of Aboriginals. For example, according to the Canadian Community Health Survey, 20% of residents of northern regions were obese and 25% smoked, compared to 8 and 12% in Vancouver. That's not just driven, by the way, by a higher concentration of Aboriginal people in the north. Average standard mortality rates were 6.4 in the southern urban part of British Columbia versus 8.4 in the Northern Health Authority. So the differences are huge. What I'm trying to say is that we have a large urban population that's severely disadvantaged and vulnerable at the level of health. The other thing is that they have less healthcare resources to mitigate these problems. What happens when, on top of the lack of healthcare resources, we get... the other thing, by the way, also is that rural British Columbians are systematically poorer and less educated than urban British Columbians. So you have a poor population, less healthy population, and less well served by many social services. And the other thing to understand is mountain pine beetle infestation. This is a climate change, secondary impact of climate change. Warm winters means mountain pine beetles infest these trees, et cetera, et cetera. We've now got, you can see from space, the mountain pine beetle infested forests. It's a red gash on the British Columbia map. And basically what this does, it creates huge fire hazard in rural communities. So you've got a poor population, poor populations surrounded by an amazing fire hazard. And if you look back at Mike's map of intense fires, they were mostly concentrated in central BC around these areas. So the potential for the direct effects in the near future on poor, already vulnerable seniors with little healthcare resources in communities surrounded by forests that are really ready to burn is a huge, big deal. And the lack of action by municipal governments and provincial government on this, in spite of the fact that they've been exhorted to move on this, is terrifying. And the rural and remote communities are going to be hugely at risk at this thing, and it's going to be a double whammy climate change thing. The mountain pine beetle is a climate change issue, and as the secondary effects of fire and air pollution on these rural communities is going to make it a big deal. Poor and elderly, pretty bad too. How much time do I have left? Okay, I want to say something really quickly. This is new work. Proportion of food imported into BC. Okay, that's we import 30% of our meat into BC. We import 80%, 75% of our vegetables into BC, 80% of our fruit. Nutritionists are telling us to eat more of these things, particularly the elderly. Okay. Where do we import these foods from, and what's the likely impact of change on these areas? Oh, God damn it. Okay. What's that? That doesn't matter. It's okay. This is what I'm trying to say here. This is America. We import about 60% of our vegetables, this black slide, and about 70% of our fruit from the United States. Here's the story quickly. Where do we import these from? California. What's happening to California? It's real dry, folks. And anyone from the States knows this. And this is part of the new work that we've done here to talk about import patterns. So the foods that nutritionists in this province and country are exhorting us to eat more are going to be the most expensive and inaccessible for folks, particularly elderly folks on fixed incomes. The question is, will poor British Columbian seniors be able to afford these foods in the future? I think I'm out of time. I'll just end it there. Thanks.
Thank you very much. We're now on to our last presentation of the conference, which is Tim Tuccaro. I think Tim has already been introduced in certain contexts, but I will introduce him yet again. Tim is a physician scientist and is associate professor and associate dean for research in the Faculty of Health Sciences at Simon Fraser University.
That's good.
Good. Okay. Presentation up.
Thanks.
Well,
as the topic, climate change is certainly a marathon. Probably all of you feel like you've been in a marathon during this conference, and I will try to go through this as quickly as possible. What I want to talk about is waterborne illness and the impact of climate change because waterborne illness is a particular vulnerability for elderly population. So what are the threats to drinking water resources? These are both local and global. Sea level rise has been mentioned, extreme weather events, snow and ice storage capacity, because there is a relationship between water quality and water quantity, and so storage capacity is quite important. What I'm not going to really have time to get into, but I think what are important research questions are what is needed for increased adaptive capacity with regards to drinking water, and who and where are the vulnerable populations, questions that have been asked by almost every presenter. So we've talked about increased heat stress events, increase in ozone and other air pollutants, drying of woodlands and increase in forests and range fires, shifting infectious disease patterns. I'm going to talk about waterborne disease. I'm not going to talk about migration from warmer climates, but actually this is probably quite important for British Columbia and may have an impact on resources for the elderly as well. Why is there increased water stress in BC? Well, part of it is due to this increase in extreme weather events we've experienced, reduced in glacial and snowmelt storage, reduced drinking water storage, hydroelectric and irrigation, threats to river biology, particularly related to fish, and that resource for food. Sea level rise and saltwater intrusion into fresh water is a real threat along the coast, and coastal land instability and shellfish food supplies have been mentioned. The photograph you see there is one of my favorite glaciers in BC. This is the Illecillewaet Glacier, and what you see from the lowest curve is 1887, where the glacier was, and subsequent years up here to 1931, and this picture is from early 1990s. With the recedence of the Illecillewaet. This is my slide to impress upon you the increase in extreme weather events. This is global data from Munich Reinsurance Company, but the point I want to make primarily is that the increase, of course, is not in geophysical events, the red, but the increase in meteorological events in green, or hydrological events, flash floods and storm surge in blue. These are the major increases in extreme weather events that will affect water supply. In terms of glacial surface area in British Columbia and Alberta, this is unfortunately uniformly reduced across the two provinces from 1985 to 2005, and you can see the various levels of reduction around the province. This I got from Stephen Shepard's group. Stephen, you've heard from already at the conference, and what I just want to march you through quickly here is the April 1st the snow line at April 1st over future climate change scenarios for the North Mountains. So you see here North Vancouver and our water supply. So this is 2020, 2050, and 2090. So I recommend that you do not buy in advance your Grouse Mountain ski pass. So this is just IPCC data, which, as most of you probably know, the sea level rise predictions are based on thermal expansion alone. So this does not include Greenland ice sheet. It does not include West Antarctic ice sheet. And in the next assessment, they are going to try to, within these incredibly large uncertainty bounds, describe what that additional input will be to sea level rise. It is somewhere between a doubling and a quadrupling of the current 1 meter estimate by 2100. So how does drinking water change in this kind of changing environment? there's the increase in waterborne gastrointestinal illness rate, which I will talk about. Globally, this is a huge concern today. 2.2 million annual deaths, mostly in under fives, and mostly in developing countries. But in overdeveloped nations, such as North America and Europe, gastrointestinal illness also is a high morbidity. Days of work missed, health system burden, and particularly the vulnerable populations like the elderly and the very young are affected by these. The economic impact is estimated in British Columbia to be 514 million annually. There's very limited data on the relationship between water quality and diarrheal disease, surprisingly. But what data there is suggests that the elderly are more at risk, and this is data from Philadelphia, 1992, a one-year study of hospitalizations showing that the relationship between turbidity in water, which is just the sediment in water, as a surrogate for bacterial contamination, has a relationship with the over 75s much more likely to be hospitalized with diarrhea during a turbidity event. And those of you from Vancouver will recall this city just a couple of years ago had a 2-week boil water advisory secondary to turbidity, one of the most advanced cities in the world. Why is there a higher risk of diarrheal disease at over 60? One thing is the incubation period for Cryptosporidium, a major parasite, is shorter in older persons. There appears to be a greater secondary person-to-person transmission in elderly. This is particularly true for institutionalized elderly. The immune response to infectious disease is reduced in elderly. And then finally, the reduced mobility, which was very clear in the Chicago heat wave. Those who could not rehydrate themselves and had a reduced thirst response were more likely to die. And then finally, there's this question, and I don't know that it's true, but based on other communication issues with the elderly, there is this possibility that they will not respond to boil water advisories as readily as those who might be more connected. And the boil water advisory issue is important because in Canada, in 2008, for example, there are 1,760 boil water advisories in different communities across Canada, and you can see that British Columbia leads the pack, which is a source of some embarrassment, I would say, for this very wealthy country. Our work has been largely related to water source and GI illness rate, and what you see here is a township in British Columbia with water source and individual cases indicated by the type of water system, so squares for surface groundwater mixed system, triangles for municipal groundwater, and circles for private wells. You can see that the cases do concentrate in the most populous areas, and as expected, it's the less populous areas that have more private wells. What was remarkable about this study was the consistency of our data across many years. So from 1996 to 2005, you can see that the municipal systems, not surprisingly, have a lower risk of GI illness related to water, and that the private wells are consistently high. What this graph does not show is in the table here that there's also a gradient within the municipal systems, and that the groundwater is most safe, as one might expect. But if you have a municipal system with a mixed groundwater and surface component, then you're at intermediate risk to the high risk in the private wells. And we took this data and began to ask the question of what would water source look like in the future with extreme weather events increasing, and with the snowmelt storage capacity being reduced, is there likely to be a signal in the GI illness rate? So, as I mentioned, there's a relationship between water quantity, water quality, and safe drinking water. Sustainable access is obviously important as well. And how does climate change impact these various components of our safe water supply? Well, one thing we do know is that there is a seasonal effect in the water supply. And as Hippocrates noted, every disease occurs at any season of the year, but some of them more frequently at different times of the year. And we know that changes in geographic distribution and seasonality of infectious disease is one of the first identifiable associations noted in climate change. Numerous studies have documented seasonal variability in the GI illness rate. So, for example, we see a peak in warm summer months for bacterial disease and early fall for protozoan disease. This is something that we've seen in our data as well. There's considerable anecdotal evidence to suggest that precipitation plays a big role in the risk of waterborne illness. So Walkerton was triggered by extreme weather events. There is also this relationship between precipitation and waterborne outbreaks. So the data that I showed you from Langley was the baseline and endemic GI illness rate, not illness from a failed water system or an extreme weather event. But clearly these events do also precipitate outbreaks of GI illness beyond and above that of the endemic GI illness. So the study we're embarking on now has the goal of examining the potential impacts of future climate change on the risk of GI illness in small BC communities with different types of water supply. We want to describe the temporal and spatial relationship of GI illness, to examine the relationship between extreme weather events and GI illness, and to look for linkages between aquifer characteristics, for example, turbidity risk, and the vulnerability of the drinking water system. And finally, to describe links between water quality, human health, and expected climate change in these communities. So how does this go together? We do know that from other studies, heavy precipitation increases turbidity. But is there a relationship between the sort of steady rain that we have here? It doesn't rain in large packets, at least not usually. We have steady rain for more months than I care to count. But what about these periods of the first rains after a long dry period? In the developing world, it's quite clear that diarrheal rates are highest after a dry period and the rains begin. Is there a relationship between temperature and GI illness? And there certainly does seem to be. And then what is the role of snowmelt? All of these contribute to water system vulnerability. And the question really is this increased risk seen in both the sporadic GI illness that you saw for the BC community I showed, as well as waterborne GI illness outbreaks when the system fails like it did in Vancouver a couple of years ago. So we have 8 different study communities. There's 2 mixed water communities, one dominated by rain, the other by snow. There are 2 groundwater communities, rain and snow, 2 surface water communities, and then mixed surface and groundwater regimes, both in the rain and snow. We are looking at sporadic GI illness. These are reportable illnesses, so our outcome is pretty well documented insofar as the people that go and actually access a doctor and have their stool checked for the organisms. And this comes from our IFAS Integrated Public Health Information System. And then the predictors that we're looking at are largely weather-related, daily precipitation, snow depth, temperature, water source related, the ground water versus surface, municipal and private systems. There are a phenomenal number of private systems performing services for communities in British Columbia. And then water system characteristics such as watershed protection, hydrogeology, and the size of the system. So I will just quickly present our initial findings that are descriptive. This is the cumulative incidence per 10,000 people over a 10-year period. And you can see that the surface water source are of higher risk, just like we would expect from the previous study. What is a little surprising here is that this groundwater snow source also seems to be high risk, and then that this mixed rain water system, similar to what we found previously, is higher risk. The age information is quite consistent with what's been shown in other parts of the world, and it's rather interesting. There's the expected bump in the under 5, but the highest risk group actually after that is the ages 20 to 29. So this group, we believe, may be engaging in more risky waterborne illness behaviors. But the point of this slide really is to show that the older population is still at some considerable risk, and the severity of that risk is much higher. There's higher fatality rates and higher hospitalization rates as you get older. This is a similar slide, and I wanted to show this because it appears that the surface water risk may be higher in the older age group compared to the peaks here, and that's something that may have public health implications. This is just some exploratory analyses showing the peak by month, and this is very similar to what's seen in other northern climes, that there is a peak of bacterial disease in the July-August timeframe, and that the parasitic disease or protozoan disease is later, suggesting that there are different pathways for that effect. So future research needs, I'll just end with this. What are the characteristics of extreme weather events that increase drinking water hazards? Are those events that occur after the dry season more important? What are the water system characteristics that increase vulnerability to extreme events? If you have groundwater protected, are you going to be able to withstand climate change? If you are reliant on snowmelt, are you going to need increased reservoir capacity? When waterborne hazards increase, what interventions are effective at reducing the health risk? So this is a lot about communication and messaging and having the available alternative sources. And then finally, can interventions be targeted to the most vulnerable, isolated elderly population? We've talked a lot about this at this meeting. I think there are many synergies to be gained from connecting elderly populations for heat events, for weather disasters, for earthquakes, for all of the stressors that those vulnerable populations face. And we need better integration of those communications. Thank you very much. This is my acknowledgement slide. And I particularly would like to acknowledge Lindsay Galway, a PhD candidate who is working so hard on this project that I described. Thank you.
Okay. We've got about 10 minutes for this session, so I'd like to invite people in the audience to ask the panelists any questions or make comments.
Is Alex? Alex, sorry. Matthew White from Simon Fraser Environmental Physiology. You got cut off a little bit there at the end when you were mentioning your bit on the food being purchased, food and vegetables being purchased from California. Could you just finish up on that for us, please?
Be more specific. What do you want?
Well, you were mentioning that it was dry in California. The costs of fruits and vegetables were going to go up, and this is what the nutritionists are recommending for for everyone to eat.
Right.
Did you just want to expand on that?
Sure. First of all, in my view, thinking about climate change around these social issues is a mistake. The first thing is that we're talking here about climate change's impact on food prices in the context of British Columbia importation of food policy, right? The thing is that there are other drivers other than climate change which are influencing the price of food that are more important than climate change in the immediate term. For example, the Chinese consumption of pork products, which require grain-fed beef, is shooting up at such a rate it's hard to imagine. That's going to drive the impact on the price of vegetables and fruit available to BC seniors in this province. At the same time that's going on, that's going to be the larger driver. A secondary driver is going to be what's going on in our main drought-ridden place of importation, which is California. So I think part of the issue here is that there has to be more complexity in our thinking here. And for example, around these indirect effects, particularly, like increased impact of food prices on the health of seniors, you've got to bring in a whole social framework that looks at the drivers, what's driving these prices. And climate change, I'm kind of, that's not the real story here. But the real solution is to link that with these other major drivers, then move to a way of building resilience among these vulnerable populations, just as you mentioned. It's not just about intervening to stop a climate change disaster. It's about building generalized resilience in populations in order that they can deal with multiple things that are happening to them, not necessarily climate change issues. Does that help?
But if I could just follow up. And I was under the impression, at least, that I thought that much of the water in California came from the Pacific Northwest, which they use to irrigate their crops, which they sell back to us. So there seems to be a bit of
the Colorado River is the primary source, and as in the last present tour showed, the rapid rate of glacial melt is going to screw the Californians and screw our seniors in terms of food importation of fruits and vegetables. One other quick thing I can say. Canada, the other day, Manitoba signed a deal with Minnesota. Quebec is building transmission lines. With carbon trading, what's happening is Canadian water is now being used to generate electricity to offset what's going on in America. So our water, this is an unusual way to think about energy, is being used to grow food, it's being used to provide clean drinking water, and it's being used to provide energy to the United States. The drawdown, multiple drawdown on that is going to be a big deal. And trying to figure the complexities out with that, people aren't even beginning to think the way they need to about this issue.
Any more questions? I've actually an observation, a question to Larry. Was Larry? Oh, hi, yeah. Your pizza. You mentioned pizza, right? And how much energy is included in a pizza, and what it can actually power? Like in terms of.
Well, on the way in, I noticed there was a pizza place right outside. And it's sort of
Yeah. No, I'm just an observation here. I'm a cyclist, right? And I don't own a car, and I do a hell of a lot of cycling around Vancouver. And from being a cyclist, you just realize how screwed up the world is. That actually gas is cheaper than to power a motor car than it is than the food you require to power a cycle. For example, if you're going to do a 200-kilometer bike ride and you were to carry 35 gels required to do that 200 kilometers, you'd be spending more than you would on the gas to take you there.
Another way to think about it is
Yeah. No, it just puts things into perspective as that there are a lot of things the wrong way around in this world, and that changing the inertia in the way that we do things is really, really very, very hard. You know, how do you change people's behaviors? Because driving around in a car is actually cheap for the way that we do things. It's way, way cheaper than it should be. It's comfortable, and it's a lot safer than cycling. You know, and to change our behaviors within our society, and to redesign our cities and to change those behaviors is a real challenge. And we've heard about a lot of the problems, but the solutions to me are massive. You know.
Thoughtful set of comments and a question in there is, I guess, the energy water probably costs in the grocery store. I think as much or more than
Still more than way more than gas.
Yeah. So it's hard to believe that. Yeah, right. So you've got a number of different factors, but energy prices. The reason I put that there is I was coming at it from a transportation perspective, but then it's tied directly to food policy and the usage of food for energy or water. And all those things are intertwined, and they're obviously really complex. I was just looking at one wedge of the pizza pie, I guess, but it's pizza was really it was just a metaphor, and I saw that graph, and we'd written that paper on carbonless footprints, and sort of backed into that because trips they use energy. So what we're looking for is a common denominator to integrate climate change with health. Is what was going on there, and it was just looking, and it is just a simple concept, but it leads to lots of different potential directions, and I hope thoughtful ideas like you had there can be maybe measured.
It just got me thinking laterally because it's something as a cyclist concerns me, it makes me think of the world in a somewhat different way.
On the solution side, obviously, there has to be research done to identify what, if we were to internalize the externalized costs on the environment from our transportation investments that we make, and I'm coming at it from my little piece of this, which is the land use transportation side. Here, other expertise, you look at all different wedges of this, but it seems like we would have to evaluate what the cost would be if we were to internalize these externalities in our decision-making process, how we prioritize investments.
It's another good reason that we should ban pineapple ham pizza.
Anybody else?
Absolutely.
On the way over to you.
The last slice will be worth a fortune.
Just a question for Tim. I've been attending an emergency preparedness conference where they've did a lot about the Hurricane Igor and all the predictors and the preparation. It would seem to me that some of the items that you point to should be triggering public health advisories, announcements, and so on, so that people could, in fact, prepare for what seem to be pretty predictable outcomes from the change of the first big rain after a dry spell and so on.
Yeah, I wish I could say that the research was far enough along to be able to do that. I think we're still at the early stage. And a lot of it is intuitive. I think that's what you're implying here. But short of the boil water advisories, which I was a little reluctant to use that slide because there's a lot of caveats I didn't have time to get into about it. Boil water advisories in some areas are used sort of as an excuse not to do anything. Some of those communities have had boil water advisories for years. And so I think, yeah, there is some wedges with regards to the boil water advisories. With regards to this relationship between extreme weather events, that is a work in progress, I think. And maybe in a few years we'll be able to offer something with regards to planning for these extreme weather events. You know, the flooding and hurricanes, those are obvious. The endemic GI illness thing is less obvious, and I think sort of flies under the radar.
Okay, I think we better bring the session to a close. And one more quick observation.
Yeah. Well, I just wanted to follow up on the nutrition question, teaching nutrition.
Okay.
On the flip side, the cost of fruits and vegetables are going to go up. But then when we look at the health benefits of eating the fruits and vegetables, where three of the four leading causes of morbidity or death in Canada are related to diet: cardiovascular diseases, diabetes, alcoholism. I think it's there needs to be considerable different angles taken on carbon footprint when we're looking at the cost to the different countries that are working to reduce CO2 emissions and improve the climate and global warming, because the costs of not maintaining a healthy lifestyle is going to compound or be compounded. So.
Okay, thank you very much. I've been asked to make one or two closing remarks about the conference, and I'm not going to belabor the point. I'm not going to spend half an hour talking about that. First of all, I'm actually unsure what to say. Usually at this point, the usual thing when you draw things to a close is to repeat the opening remarks just in the past tense. Yeah? That's the easiest way of doing it. But I'm not going to do that. Really, the aim of this conference has been to bring together people from many different backgrounds and countries to address the climate change, the issues of climate change and population aging. And when myself and Gloria and Heather got together to discuss this, we really didn't have any more specific objectives than to bring people together, to discuss things together, and to share our knowledge and experience, because this is such a new area of thought of how to link population aging and climate change together, that really we're at the start of what I think should be an exciting avenue for collaborative research. I think we've done a really good job over the last couple of days, and during the think tank that we had on Tuesday as well, about kind of coming to some ideas about the things that we know. Things like that climate change is happening, that this is going to lead to certain things like extreme weather events, general changes in conditions. We've been talking about British Columbia, which may not be particularly associated with hurricanes, etc., but there are lots of things which might affect the weather conditions and the environment of British Columbia. We've also talked about the vulnerability of older people, their health, their vulnerability in times of disaster, and issues around security, which have been talked about. And I think we've done a really good job in kind of summarizing the issues from many different perspectives. If we go on to those areas that we know we don't know, I think some of the things that I thought about was that the solutions still seem to me very difficult things to address, whether that is at global level policy or local policy, and then issues around practice about giving advice and helping people, particularly seniors, in the future as climate changes, are really challenging, and really it's beholden on the research community to mobilize our knowledge and really feed this into policy and practice. But the research is not going to be easy, because what struck me is that this is a very, very complex area, that we need to have a complex systems approach, and this will be a real challenge. One little disappointment that I had, if we're talking about knowledge with this conference, is that we were a little bit unable to mobilize interest from the gerontology field, surprisingly. And I think it's beholden on people such as myself and Gloria to really try and highlight this within our gerontological community in the future. Say, for example, in the Canadian Association of Gerontologists, the IAGG, and the Gerontological Society of America. I think when we look at research, though, some of the interesting things are the things that we don't know. So what are the things that we don't know we know? The big issue here, to me, is that we've got people from many different disciplines, and we all have a lot of knowledge, but because of disciplinary boundaries, it's really difficult to share that knowledge. And I think if there's one thing that I would really like to see coming out of an event like this, is to develop networks where we can really share our knowledge, to develop real interdisciplinary work, which is about sharing concepts, developing new methods, identifying research agendas. And hopefully that will have happened organically within the conference. If we think about the things what are those things that we don't know that we don't know? Okay, the real intangibles in here, what's going to happen in the future. So as researchers, I think one thing which I've learned within gerontology is that really research should be participatory, that we should listen to the people in the community, that our research should be stakeholder driven. And I think that should be things that should be setting our agendas. So those are the sorts of things which kind of the take-home messages that I have. So, not to belabor it, I will now go on to the thank yous. Okay? First and foremost, I'd like to thank Gloria Gutman and Heather Stewart for their absolutely... Organizing an event like this is a huge task. Okay, we did it last year with a conference, and Gloria did a great job. Gloria is one of the greatest conference organizers, probably in North America. Okay, so here's some tokens of appreciation for Gloria. I'd also like to thank our helpers, particularly Melinda Aiken, who was helping out on the desk, Ray Adams, who always moans about things but does a great job in the end, and Claudine Claridge, who is Claudine's there, who volunteers for a lot of these events. So thank you for the helpers. I'd like to thank our speakers and contributors who I've been so impressed by the quality and the standard of the presentations. It's absolutely top quality. I'd also like to thank our sponsors, particularly funding from the Canadian Institutes of Health Research, which has helped to fund this event and bring people from around the world. And I'd finally like to thank everybody who participated in the conference. I hope you found it informative and stimulating. Thank you very much.